When neurosurgeons remove a cranial tumor, they affect the whole nervous system. This includes endocrine function, motor control, memory, and cognition. In rare and unique cases, such as this large craniopharyngioma, a skilled surgeon can even impact the person's core arousal and consciousness. Craniopharyngiomas have a bimodal age distribution, peaking at 5 to 14 years old and then again at 50 to 75 years old. Symptoms are typically insidious and vary, ranging from visual, endocrine, headache, depression, slow cognition, or lethargy symptoms. They are typically histologically benign, but locally aggressive due to mass effects. There are two histologic subtypes. The adamantinomatous subtype, which has increased signaling in the Wnt pathway with increased production of beta-catenin, and the papillary subtype, which has increased signaling in the BRAF pathway, which is also seen in other cancers, and therefore can be treated with BRAF inhibitors. Both types have similar resectability, sensitivity to radiation, and overall survival, and most have a solid and cystic component with the classic crankcase oil contents coming out as it is perforated surgically. Our patient is a 76-year-old male diagnosed with Parkinson's disease in early 2024 after about 2 years of insidious symptoms. Unfortunately, he started having new vivid hallucinations around Halloween of 2024, which prompted a neurology diagnosis change to Parkinson's disease with Lewy bodies. His symptoms have kept accelerating since October of 2024 to now include paranoia, memory loss, balance issues, and eventually profound sleepiness. A new MRI showed a third ventricular mass and obstructive hydrocephalus consistent with craniopharyngioma. Interestingly, an MRI 4 years prior was read as normal. On pre-op physical exam, he was awake with a flat affect. He was occasionally oriented to name, but not to place or year. He intermittently opened his eyes, and he moved all extremities spontaneously and purposefully, but most of the time did not follow commands. The pathophys here is uncertain and a ripe area for future research. There could be mass effect on thalamic arousal pathways. Prior research has shown with DTI imaging that there could be structural degradation of white matter tracts in these patients. Additionally, abnormal functional connectivity within the hypothalamic and DMN circuit could play a role too. There was a transphrenoidal resection of the mass performed on June 3, 2025 at Pennsylvania Hospital. Dr. John Lee and his team managed the case. First, an EVD was placed. Then, the ENT team created an endonasal corridor. The neurosurgical team then did some sellar drilling. Then a T-shaped dural opening was created. The tumor was visualized and identified. The cyst was excised. There was a visual inspection of the third ventricle. And then a graft harvest occurred from the right thigh. And then there was a skull-based reconstruction with closure by ENT. The post-operative physical exam findings have been stable. There's some expected pneumocephalus and a continued mass effect on a post-op MRI. There was some hypernatremia peaking at 153 and some DI treated with DDAVP. The operative effects on the patient's cognition may take weeks or months to realize as the brain adjusts to the new physical environment and the patient medically improves and the pneumocephalus improves as well. The takeaway from this case is that although diseases impacting cognition in older adults are not uncommon, you should consider imaging in patients with quickly accelerating cognitive decline when a clinical diagnosis is presumed without supporting imaging or pathological studies. Special thanks to the mentorship and learning opportunities provided by Dr. John Lee, the neurosurgeon on the case, Dr. Stephen Brem, the neurosurgery clerkship director, and Dr. William Welch, the Pennsylvania Hospital neurosurgery clerkship director.